So Karen, what I was saying was, um, go ahead and introduce yourself because there are people out there who don't know who you are, and then go ahead and get started.
Okay. Hi, everybody. I'm Kiran. I'm one of the first year fellows at Seattle Children's Hospital and at the University of Washington. So thank you for joining us really early this morning to learn all about severe asthma and alarmins in asthma. I would say this is a fairly new topic of the decade, more so in the last few years. So I'm going to go ahead and get started. And here we go. Okay. So our objectives today are, before anything else, if everybody can mute their mics, I'm supposed to tell you that. I have no disclosures. So our objectives today are learning introduction to severe asthma pathways. And as we know, this is a very complex process and which has been studied for some time, but I feel like there's still room to go. And I remember several years ago while practicing that we would often admit our asthmatic patients for several days and just hope they would get better with steroid therapy and then do frequent follow-ups in the outpatient setting. And we just did not have good treatments, which has obviously changed in the last several years. So today, along with that, I want to add that I'll be talking about the role of alarmins in asthma, specifically TSLP, IL-33, IL-25, and some ongoing anti-alarmin treatment options, and the future and pros and cons of these treatments. So to start off, alarmins is a very broad term. If you start looking on PubMed or do your initial research, you'll find a lot of initial research that was ongoing, probably starting in the 90s regarding sepsis treatment. Initially, alarmins were something called, under the umbrella of something called damage-associated molecular pattern molecules. Basically, these molecules contributed to promoting inflammatory responses to injuries, like crush injuries and so on. But these could also contribute to promoting pathological inflammatory responses. But obviously, we'll focus on the asthma alarmins today. So just to start off, let's talk about severe asthma because we have to discuss this topic to go on to alarmins. As we all know, asthma is a chronic inflammatory disease affecting over 300 million individuals worldwide. And these are individuals that are actually diagnosed. I'm sure there are others out there that are poorly treated right now and are not diagnosed as severe asthma. 5 to 10% of the total asthmatics, as I was saying, have severe asthma classification. Even on their optimized maintenance therapy, they experience frequent exacerbations, tend to have high rates of healthcare resources usage, hospitalizations, clinic visits, and they tend to have very impaired quality of life. They're missing school, they're missing work, they're not able to enjoy a social life as well. And these patients are already on maximum inhaled therapy and requiring quite a bit of oral corticosteroid treatments through the year. But what is the actual definition we would look at? Let's say quad AI would say, if you look at the GINA classifications. So this would be someone requiring medium or high dosed inhaled corticosteroids combined with longer acting medications and yet still remaining uncontrolled despite proper use of these medications. And these patients tend to experience asthma symptoms most days of the week and often every night. And they often demonstrate significant reduction in their lung functions if you look at spirometry or PFTs. So currently, we have a few severe asthma treatments available, particularly monoclonal antibody therapies, which we know target the signaling pathways in type 2 inflammation, which is mediated by IL-4, IL-5, and IL-13. And we have some measurements we can do besides, lung function testing, such as blood and sputum eosinophil levels, and checking FeNO, fractionated nitric oxide. And these therapy is basically alluding to point 1 in the slide is their anti-IgE, IL-5, and IL-4. And these generally tend to decrease exacerbation in about 50% of the study population. But that's not that great, 50%. What about the rest of the 50% of the patients? I think we're missing a lot of patients that can be optimized in their therapy. And basically, we have these agents that we're using, and they, with the anti-IgE, IL-5, and IL-4/13, these produce variable improvements as measured by our lung function testing and symptom scores that we have in our offices. Could it be that the lack of complete efficacy, maybe that they're only, because we do know they only target part of the T2 high inflammation pathway, and they leave the rest of the pathway untreated? Obviously, we can't put them all on all the biologics. That would be great, but we cannot do that. Next thing is we are not really treating the T2 low asthma. That's another umbrella of this severe asthma picture. So what pathways do we target? So I think it's a very nice slide depicting pretty much what we have available at this time. So if you look at the top, talking about just type 2 severe asthma, it's divided nicely into high and low inflammation. And in the middle, I want you to observe they're connected by IL-25 and IL-33, and these are the 2 alarmins we'll be talking about down the road. Looking at the high inflammation, so there's your culprit, the eosinophil, which we're targeting, which is secreting IL-5, IL-13, and IL-4. And we have, biologic agents that target these specific pathways. So we have a few options with mepolizumab, reslizumab, and our very commonly used nowadays dupilumab, and not just for asthma, obviously. And for the IgE, we have omalizumab, and then the CRTH TH2 that you see there is basically a prostaglandin D2 receptor 2, and its agent fevipiprant. It's an oral medication for allergic asthma, essentially. Is a oral prostaglandin receptor antagonist. So that is in the picture there, but these are all separate therapies. And then you look across at the low inflammation, and you have the neutrophil, which is one of the main pathways we look at for low inflammation, low T2 inflammation, the IL-17 from the neutrophil, which basically is involved in inflammation and remodeling. And the agent targeting that is the brodalumab, which I don't see used very commonly, which may enhance IL-17, so glucocorticoids can actually enhance IL-17 activity. So that is a problem which we're going to talk about down the road. And so we have several other options here as well, the mast cell under the paucigranulocytic inflammation with the c-KIT, basically, which is a gene in the mast cell development. So this is a busy slide, but I think it's a very important slide to get an overview of what we have available today. So what we just basically talked about is hinted here. So our major asthma pathways are driven by T helper type 2 cells and type 2 innate lymphoid cells, and I'll be calling those Th2 and ILC2 going forward, which we are basically looking at the IL-4, IL-13, and IL-5. What do these 3 do? So IL-4 signaling leads to B cell class switching and triggers release of IgE. As you can see, that could be a problem with asthmatics. IL-13 regulates IgE synthesis, mucus hypersecretion, airway hyperresponsiveness, and fibrosis, which we know leads to airway remodeling. And those all can be a problem if this is dysregulated. And IL-5, which is, it's going to come up a lot. IL-5 is an effector of eosinophilic inflammation, which also leads to airway remodeling. So another helpful slide looking at the crazy pathways of asthma. And I think this is very simplified, actually, although it looks like a busy slide. Asthma is a very complex process. So if you look at the very top, there's all sorts of triggers that affect our epithelium, airway epithelium. So we're looking at allergens, all sorts of environmental pollutants, microbes. You can see cigarette smoke there, for example. So they're affecting our airway epithelium, and our dendritic cells pick up on that. And then all the cascade pathways, as you can see at the very top, the alarmins are sitting at the very top. So IL-33, IL-25, and TSLP are at the very top. And the cascade effect below, leading to Th2 activation. And if you look at the right side of the screen, there's the ILC2 pathway as well. Everybody is secreting IL-13, IL-5, and IL-4. So these are all basically a cascade effect, in a way you can say, leading to IgE secretion, which further activates mast cells to increase further cytokines. And then all these together affect our smooth muscle cells. As you can see, a lot of these are targeting our eosinophils. And at the very bottom, you can see it's divided into, I think very simply, into allergic eosinophilic airway inflammation versus non-allergic eosinophilic airway inflammation. The end product still is remodeling and patients' poor quality of life. As similar to what the previous slide was depicting, I just want to add another one. This one I thought was a little bit simpler than the previous slide. This one, again, inflammatory mechanisms, which can be associated with the granulocytic inflammation, nicely divided into type 2 inflammation on the left side and non-type 2 inflammation on the right side. So again, we see TSLP at the very top on the left side, and then subsequently we see the other, the activation of the Th2 cells, and then ILC2, and all the pathways we were just talking about, essentially leading to B cells secreting IgE, mast cells releasing histamine, and I will talk more affecting the IL-3, 4, and 5 pathways. And on the right side of the screen, the inflammation we don't talk about as much related to neutrophil is just as problematic. As you can see in the picture below that one, these all lead to an abnormal airway. So, and I think that's a picture we've all seen. The hyper responsive smooth muscle, then it's leading to constriction, and then we have eventually smooth muscle hypertrophy and collagen deposition over time, and having chronic changes. So as I was alluding earlier, our airway epithelium is a very complex, busy place. It is an active front line in a way. It responds to external triggers, allergic and non-allergic. And then these triggers, I've mentioned many times, can be several things, including cigarette smoke and even gasoline exhaust out there. Essentially, these release epithelial cytokines, which we were discussing just a minute ago, including TSLP, which stands for thymic stromal lymphopoietin, IL-33, and IL-25. Interesting thing about TSLP is that for several years, it was just looked at for B cell differentiation, looked at a lot of GI studies. Looks like in the 90s, they were looking at its role in the gut. And very recently, we're looking at the airway role. And TSLP is secreted not just by the airway epithelium, it's found in several parts of our body. So and that is, I think, important down the road when we are looking at biologic agents targeting TSLP. How does that affect everything else? Other alarmins instigate downstream alarmins instigate downstream pathways, as we were discussing the T2 and the T17, which is the neutrophil path. So as I mentioned earlier, as we looked at one of the first slides, acute asthma exacerbation inflammation pathways are similar to the chronic pathways I was just talking about. Specifically, acute asthma exacerbation can also be divided into eosinophilic versus neutrophilic versus mixed versus polygranulocytic inflammation. And this is driven by, again, simultaneously active T2 pathways. We several studies, and I didn't quote a specific one because there are several studies showing human allergen challenge studies, which show increase in airway IL-4, IL-5, and IL-13 levels during virus-induced asthma exacerbation. And a common virus they look at is rhinovirus. Less is understood about the non-eosinophilic or neutrophilic inflammation pathways in relation to the acute asthma exacerbation, but I think that one is just as important. And there are studies looking at airway microbiome involvement specifically. So as far as further detail about acute asthma exacerbation, association between inflammatory asthma phenotype and specific triggers is actually poorly understood. You would think after all these years of all these studies, we would understand this better. Virus-induced exacerbation is seen more commonly in allergic asthmatics, asthmatics that have elevated pheno or blood eosinophils at baseline. As I mentioned earlier, and I think you guys will memorize this by the end of my lecture today, eosinophils activated by IL-5, and they drive the pathophysiology in eosinophilic asthma, and they tend to play a role in defense against viruses. So the question is, why do patients with asthma with high eosinophil counts still experience virus-induced asthma if eosinophils should be helping with that? So in virus challenge study in patients with mild asthma, they were given anti-IL-5, for example, mepolizumab, which attenuated eosinophils, altered part of the immune response, including the B cell, macrophages, and the neutrophil response. Despite doing that, they did not find associated improvements in their lung function. So what are we missing? Only more questions come up, so we need better understanding of drivers of these exacerbations. We obviously have limited knowledge of heterogeneity of this inflammation. There are actually studies ongoing looking at the specific biologics I mentioned earlier, looking at each asthma phenotype and each specific trigger, but that in conclusion will take a long time. That's a lot of factors to look at. So maybe we should look at targeting multiple inflammatory pathways, such as the alarmins, because they're at the very top of the cascade chain. The same slide we saw earlier, because I think this is a good one depicting what I'm trying to say. At the very top of, right below our airway epithelium, you see IL-33, IL-25, and TSLP on both sides, as well as for the allergic eosinophilic airway inflammation and the non-allergic eosinophilic airway inflammation. So it makes sense that we view these alarmins more carefully as they target the same pathway. So basically, recalling the diagram we just talked about, specifically TSLP, IL-33, and IL-25, we do know that TSLP and IL-33 play a key role in driving T2 inflammation. IL-25 is less understood. There are actually genetic studies showing that TSLP has identified alleles associated with asthma. There are tables in Middleton just with this information of the possible alleles. Similarly, certain alleles in IL-33 and its receptor, which is ST2, have been shown to be associated with asthma. For example, a rare IL-33 loss of function mutation has been shown to reduce blood eosinophil counts and protect from asthma. TSLP levels in bronchial alveolar lavage fluid levels and biopsies have been shown to be elevated in patients with asthma compared to healthy individuals. And it's been shown to correlate with disease severity. Now, there's also a negative correlation with FEV1 values with the TSLP levels. As we see TSLP levels go up, the FEV1 values dropped. Similarly, levels of IL-33 and its receptor ST2 are found to be higher in serum and BAL samples of asthmatics than healthy patients. Patients with allergic and eosinophilic asthma phenotypes tend to have higher serum IL-33 levels as well, those specific phenotypes. And looking at just the ST2, which is the receptor for IL-33, patients with allergic asthma, they have a ST2 expression on eosinophils measured in the blood and sputum has been found to be upregulated after allergen inhalation challenge. And similarly, you tend to find higher soluble ST2 levels and when a patient is experiencing, these asthmatics are experiencing exacerbations. So TSLP in itself has a large role compared, it's more understood than our other alarmins, the IL-33 and IL-25. It is seen to have a potently, it potently activates dendritic cells. Many of its role also include, it's shown to induce production of Th2 attracting chemokines, such as TARC, which is thymus and activation regulated chemokine, or also known as CCL17, and also attracts chemokine CCL2, which is L22, which is macrophage derived chemokine. TSLP also activates dendritic cells to basically prime Th cells to produce inflammatory markers, mediators, such as IL-4, IL-5, and IL-13, the main ones we work with. And then as it's releasing more of the IL-5, which we know leads to eosinophilic recruitment, you also see a release of cystenyl leukotrienes, an increased release of these cystenyl leukotrienes, which are seen to be potent bronchoconstrictors. So essentially, all this leads to airway remodeling, which I just want to define real quick. Essentially is smooth muscle proliferation with the release of transforming growth factor beta, and then interaction with mast cells and epithelial cells all collectively leads to remodeling. Mast cells themselves also release cystenyl leukotrienes and histamine and prostaglandins, we know that. So it's again, another cascade effect going in circles. TSLP, so IL-4 and IL-13, due to TSLP, are secreted from the polarized Th2 cells, which is due to the TSLP. These activate B cells to further produce IgE, and that further leads to airway hyperresponsiveness and triggering of the mast cell degranulation. IL-13 in itself, as we discussed earlier, increases mucus production, which is basically goblet cell proliferation, and also increases airway inflammation, which is which can be seen through epithelial production of FeNO. So it activates cell types that release IL-13 as well. So TSLP also activates mast cells, basophils, and ILC2s. So overall, it has its hands in every part of the pathway. and I want to show this in illustrative form. I know it's difficult to listen to what I was saying. It's a lot of reading and a lot of listening there. So if we look at the airway epithelium in the top photo, as you can see, a lot of irritants, including a big dust mite there, are affecting the airway epithelium, leading to our dendritic cells picking up these triggers and activating the Th2 cells, and then help the other T helper cells, leading to activation of eosinophils, and the whole pathway there is leading to goblet cell metaplasia. We're seeing bronchial hyperactivity, and then at the very bottom, the bottom screen there, you see specifically the alarmins, the IL-33, 25, and TSLP are similarly part of the role here, affecting the ILC2. And all these together are leading to tissue remodeling. So we've talked a lot about TSLP so far. So IL-33 is another alarmin that I've been mentioning. It is actually a positive regulator of TSLP, dendritic signaling, initiating and maintaining Th2 cell mediated inflammatory responses. It also stimulates lung mast cells to release histamine and IL-13, which we know can lead to airway constriction. IL-33 also promotes mast cell survival and their cytokine production. It also is known to promote eosinophil survival and basophil activation, survival, and proliferation, and has been shown to increase release of IL-13 from ILC2s. So I would say, although TSLP may have more information out there for itself, IL-33 is pretty problematic too. Okay. And just to show in illustrative form, IL-33, as you can see at the bottom image there, is at the very top again, just as well as the TSLP. Although I know IL-25 is listed there, it is less understood. Its role is less understood. It's kind of listed together. But IL-33 is just as problematic. As you can see, there's a type 2 innate lymphoid cells. It's essentially leading to release of IL-5 affecting your eosinophils, IL-4 and IL-13 release. And then there's the goblet cell metaplasia occurring due to the same reason. And essentially we have tissue remodeling in the end. As I alluded earlier, IL-25 is the least understood of the 3 alarmins, with studies ongoing. But some things we do know, it is shown to be also, like I said, driver of T2 inflammatory responses, particularly to virus-induced asthma exacerbation. Rhinovirus is the one most commonly that comes up during those studies. There are elevated plasma levels of IL-25 associated with allergic asthma phenotype. IL-25 concentration in sputum has also been shown to correlate with disease severity, as we saw with TSLP earlier and IL-33. For example, after inhaled allergen exposure, there's increased expression of IL-25 and its receptor, and it's shown in the bronchial mucosa, the dermis, circulating eosinophils, and airway dendritic cells. And that's important to see that this is, alarmins are not just being evaluated for airway inflammation, and this is also being looked at in atopic dermatitis and other atopy conditions. Asthmatics with high level of bronchial epithelial expression of IL-25 versus those that have lower levels. So the patients with that have higher expression tend to have greater airway hyperresponsiveness, greater airway remodeling, and we find more eosinophils in their blood and airway, along with elevated IgE levels and they tend to have higher allergen skin test reactivity. So all this time we have been talking about T2 high asthma. So these alarmins also have shown a role, maybe less understood than high asthma, but they seem to have a role in T2 low asthma as well. The data mostly is from animal studies though, so far. So thought to play a role in the neutrophilic pathway, which is the T2 low airway inflammation pathway, as I depicted earlier in the illustrations. So these essentially, the TSLP in this situation activates dendritic cells to induce polarization of naive T cells toward Th1 phenotype. And subsequently, you see release of IL-17, and that promotes neutrophilic inflammation. And that is usually the breakdown pathways that you see for non-allergic and non-eosinophilic responses. TSLP expression in human BAL fluid also correlates with neutrophil infiltration. So there are future studies looking at IL-33 doing similar things. I just couldn't find any specific findings to share with you. Another thing I found interesting was alarmins and their role in their possible role in steroid refractory asthma. So type 2 innate lymphoid cells, which we know may be key drivers of part of the asthma pathways, but they may be key driver of late onset eosinophilic asthma. In these, we see that TSLP actually can promote longevity of ILC2s, and IL-33 can promote activation of ILC2s. And as I was saying, ILC2s we think may be key drivers of late onset eosinophil asthma. So TSLP and IL-33 are promoting ILC2s in a way. So whilst steroids have been shown to inhibit the IL-25 and IL-33 stimulated T2 cytokines that are that you see produced via ILC2s, we don't see that with TSLP stimulated T2 cytokines. So I know that sounds like a lot of things I said there, but essentially what to get out of that is that TSLP stimulated T2 cytokine are in one study was shown not to be inhibited by steroids. TSLP levels elevated in BAL fluid in patients with asthma versus healthy controls also correlated with level of steroid resistance. Lastly, non-eosinophilic asthma with high IL-17 level and high number of neutrophils potentially result from TSLP signaling. I put that there, food for thought. So there's still studies ongoing regarding that, but that's important. So we know all about alarmins now. I think at least a good introduction to them. They're obviously very complicated pathways beyond what I'm telling you. So we have anti-alarmins in asthma. So these are good targets in the upstream role of asthma inflammation. They are a potential to inhibit airway hyperresponsiveness and remodeling. And they may produce sustained reduction in disease activity. And a good question that I have seen is, do these have a disease modifying role? So far, the biologics that we have, they're good while you use them, but once you come off of them, the disease returns. So what studies are looking at, anti-alarmins as possibly disease modifying role, which would be great. The most the more common one you may have heard about so far is the anti-TSLP tezepelumab. So this one basically is a human monoclonal immunoglobulin G2 lambda antibody. It's also known as AMG 157. It's shown to prevent TSLP interaction with its receptor complex. And This is the one anti-alarmin that has reached the furthest stage of clinical development, with many other ongoing. This one has the one that you would hear about probably in the upcoming few months. So there's been multi-center randomized trials, for example, of 550 patients with moderate to severe asthma, defined as poorly controlled on medium to high doses of inhaled glucocorticoids and inhaled LABA, with at least 2 asthma exacerbations per year or 1 exacerbation that required hospitalization in the previous year. In this specific study, there were 4 arms with as you can see, increasing dosage, 70 milligrams every 4 weeks for 138 patients, 210 milligrams every 4 weeks for 137 patients, 280 milligrams every 2 weeks for 137 patients, and then we have the placebo group with 138 patients. After 52 weeks of therapy, the annualized asthma exacerbation rates were significantly lower in 3 tezepelumab treated groups, with decreases in exacerbations at the rate of 2%, and yes, that's correct, 2%, 71%, and 66% versus the placebo group. And this is found to be it is significant with a p-value of 0.001 for all comparisons. Similar results were also observed in patients with blood eosinophils counts. Similar results were observed regardless of the patient's blood eosinophil counts at enrollment. So there are phase 2 and phase 3 studies that are ongoing. So here's a list of just a few. As you can see, just anti-TSLP, this is clinicaltrials.gov. Tezepelumab, there's a few ongoing studies. Essentially, the one I just told you about is, there's only a couple really published right now. The next one I want to talk about, at the very top is the CSJ117. That is another one that's currently being studied. It's an anti-TSLP monoclonal antibody, which is delivered by inhalation. Currently, it's in phase 1 of development. I think it's helpful to, again, look at what are we treating. This is just basically we're talking about TSLP here in this picture. As you can see, airway epithelium being irritated by several things at the top. And I like the fact that it shows just TSLP trickling down. Essentially, that is the problematic anti-alarmin, the alarmin there, affecting so many pathways, the allergic inflammation, causing eosinophilic inflammation and neutrophilic inflammation. As you can see, targeting dendritic cells, it's promoting the THO to convert to TH2, releasing so many interleukins, and then affecting our mast cells and B cells to release further IgE. Similarly, in the ILC2 in the middle there, promoting it to release IL-5, IL-13. And lastly, in the neutrophilic inflammation, our dendritic cell, again, are converting the TH0 to TH17 in this case, and releasing IL-17, which affects our neutrophils. All of these together can affect our airway smooth muscle. I just like the fact that this depicts that TSLP can treat a lot of pathways. And yes, they mentioned tezepelumab up there for you to look at there. As far as anti-IL-13, there are a few ongoing trials, but nothing really, really I can share with you right now. But there are a few ongoing trials at this time. And I did not mention IL-25 because I could not find any specific studies that are actually even active right now. So our goal of anti-alarmin treatment is basically providing broad anti-inflammatory effects. That's what we would gain out of that. It would cover multiple activated T2 pathways. which can be difficult. It can be difficult to discern what you're treating at times. Is this one exacerbation being driven by an allergen exposure, or is it due to eosinophilic inflammation? Anti-alarmin therapy can also be helpful with patients that have comorbidities. As I said earlier, studies are looking at nasal polyposis, atopic dermatitis, because these tend to have co-activation with IL-4, IL-5, and IL-13. And a lot of our patients have all these things. And then there's patients with mast cell-driven disease. As you saw, these anti-alarmins do affect the mast cells as well. So those patients may benefit from this as well. Looking at the future, so we need to look at what is the long-term safety of blocking all the alarmins. They affect a lot of pathways, which is great, but what does that mean down the road? What does it mean long-term? So like I said, studies are ongoing. We don't know. So we have to look at the risk benefit of anti-alarmin usage versus the cumulative oral corticosteroids exposure that our patients experience. This is an interesting tidbit I found, that there is something called the short form of TSLP or SF-TSLP, which is which has been studied to exert antimicrobial activities. And this was mostly in, again, GI in the GI studies, particularly in the 90s, when they were looking at ulcerative colitis, Crohn's disease, celiac disease, inflammation pathways. Short form of TSLP was studied at that time. And what they had found is that short form of TSLP actually is upregulated when there are infections with certain viruses and helminths, and even non-biologic exposure, such as environmental smoke exposure. So that's interesting tidbit there. If we are blocking TSLP, what does it tell us down the road for antimicrobial activity that our body produces? TSLP is also shown to be pro-tumorigenic, while it has also been shown to be protective in some neoplasm cases. IL-33 may be cardioprotective. That is a question. And for asthma is something to think about, is suppressing one alarmin going to be sufficient? Because these tend to, there are redundant pathways even around these alarmins. And together they're possibly potentiating their effect. So if you block one, are you really, how are you really going to be helping a patient down the road? So again, studies are ongoing regarding this. So a lot of questions, I think, but I think we also have very good answers. Okay, here are my references, and the word of the day is alarmins. And I'm going to put this very pretty picture up here. If anybody has any questions, I will try my best to answer them.
Karen, do you hear me?
Yes, Dr. Altman, I can hear you.
So the last point you brought up was one that came to mind. Since there's such redundancy of these three alarmins, it's surprising that just blocking TSLP, which is pretty soon going to be a marketed drug, was so effective when you got the dose. Is there any discussion of that?
No.
Surprising that the other alarmins don't pick up the slack.
Yeah, I mean, I couldn't find anything concrete to share with you guys. I just know that that's a question that comes up in a lot of papers that I looked at, that I think this is something that's going to come up down the road when there's people on it, thousands of people are on these drugs, and we can see effects down the road, but nothing concrete to tell you. I just found this as a very interesting question.
The other thing, I didn't know that this had been studied, these alarmins had been studied earlier in GI diseases before respiratory. Did nothing come of that? Was it a failure? Did they try therapeutic trials? Did they have monoclonal antibodies to study its effect in GI disease?
Not specifically monoclonal antibodies. I frankly don't think alarmins have been looked at very seriously until lately. Some trials had gone on, but really nothing has come to fruition until recently. So no.
I guess at the beginning of your talk, I was muted, so people didn't hear me, but we're going to have an additional talk on February 23rd by Jonathan Koren from UCLA,
Yep.
who's done, many have been PI on many of the trials with Tezi. So we'll get more focused information specifically about TSLP. That'll be from 8 to 9. It'll be a second talk that morning on February 23rd.
Yep. I think that's very exciting.
Yeah, he's a brilliant guy. Anybody else out there with questions? We've got 46 people listening. Somebody has to have a question.
I think they've learned everything they need to know. So, thank you for joining. I really appreciate it. I know this is not a very exciting topic at 7 a.m., but I think it's a helpful introduction to what we do every day. Thank you so much.
All right, well, thank you for doing this. If nobody has any other questions, we'll move on with the day.
Okay.
Thank you.
Thank you. Bye-bye.